Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between.
Good morning, George. It's Tuesday morning, and we have a good friend and somebody that's been an advocate and a great pediatrician for many years in the independent practice community.
Yes, today we have the famous or infamous Dr. Richard Lander. The title for the discussion that we're going to have today is Navigating the Pediatric Medical Practice in the Modern Era, from acute illnesses and injuries to chronic conditions. How can a practice continue to do the right thing and yet stay fiscally sound? Take it away. Dr. Lander has been a practicing pediatrician for over 45 years. He's been active in the AAP in New Jersey and the national scene. He's a coding expert for the AAP. He's been the past chair of SOPM and the Payer Advocacy Committee, received many awards from the AAP for advocacy and on managing pediatricians and helping them with the business side of pediatrics. And he's published many coding seminars at different venues and gave lectures all over the country. Dr. Lander, we always start the episode with, why did you become a pediatrician?
Well, so you call me Richard and I'll call you George.
Okay.
So to me, it's really simple. I wanted to become a pediatrician when I was 5 years old. My parents told me, if you're going to be a doctor, be a plastic surgeon, make a lot of money. I used to fight with them. I think the reason I want to be a pediatrician is my dad was on the road, took me 2 hours to get home from his office. My mother was a very nervous mother. To the point where we were going to our pediatrician's office once or twice a day. And the pediatrician finally said to her, Mrs. Lander, I'll stop at your house every day on my way home. This is what I wanted to do. I'm lucky that I've been able to do it. Not all of us can do what we'd like to do for our lives. And for me, it's terrific. I'm very happy I've been able to do this.
Did you have any families that you stopped by on your way to work?
Did I?
Yeah.
Listen, I'm old enough
as a pediatrician.
I did house calls in the early days. I mean, I started practicing back in the 70s. So yes, I would do house calls.
So let's reminisce a little bit. What kind of setting did you practice in, and has the landscape changed today?
Sure. So when I started practicing, I'm from New Jersey. It was a upper middle class to rich area. I started practicing and I found out what everyone else was charging, and I decided I'm going to charge $2 more. So a sick visit was $18 back in 1978. And back then it was just word of mouth. I was always available. I tried to be nice to my patients. If I was covering someone, I would never take one of their patients. But word spread and my practice built. Back then there was no CPT coding. You just charged a visit, the patient paid you, and then you submitted insurance forms for them to get paid back. Obviously, things started changing once the CPT came out, which affected us probably in the late 80s, and everything changed. The insurance company became the middleman, and they were taking money out of our pockets. They were doing nothing but offering insurance to our patients, their clients. So I've not been happy with the world of insurance.
Yeah.
So when you say you took $18, or was like 85% of your payments in cash?
Cash and checks. People weren't using credit cards back then. So a visit was $18. I think I charged $2 for a polio, $2 for a DPT. And it was a combination check, cash, but no credit cards, no chickens either. This is suburbia.
Yeah.
And was it, it's because I'm always reminded of Joe Serlo. He said he grew up somewhere in the East Coast. He was a surgeon and then an ER doctor. And he said that in the community where he grew up is a very Italian community. And the family doctor did house calls. He said by the fourth house call, the cops had to take him home because at every stop at night, the lady of the house wanted him to have a glass of wine or some sort of Was that your experience when you started first too, that you had to take like a meal or a dessert or a glass of wine or something to the family would just wanted to treat you for something like that, or no?
It wasn't that, and I was never a drinker. Thank you very much for coming, Dr. Lander, was all I needed. We did have someone in our community who, older than I was, making house calls for many years, and he was famously known for jumping out of the window when the husbands would come home. Things changed. Obviously, it's better to have the patient in the office. I would run to my office 10 o'clock at night back in the 80s and 90s. If somebody was sick and I thought I might need to give them a nebulizer or I wanted to do a strep test, I was running back to the office at nighttime to see my patients as well. It made more sense.
How was the record keeping progress notes back then?
Oh, they were great. For someone like me who has a horrible handwriting, I can't decipher my notes from almost 50 years ago. Very minimal. Yeah, you saw somebody that had an ear infection. Your notes were the date, LOM, antibiotic. It was terrible. It was terrible. And certainly that changed very quickly as I realized I'm not going to remember everything I did with the patient. You have to more complete notes. And before using EMRs, I had templates for my paper charts. So which would help me see patients a little bit faster, but still know that I covered all bases, be it in part of your history or the physical exam.
Yeah, I remember when we took over one of the practices of a senior physician back in 2003, we were cleaning out some of the charts, and I would find these records that had that yellow piece of paper with about 40 visits on it, like a lunch paper, LOM amoxil. And that was the visit. And then a little scribble of $5, $10, however the office visit was. That has, over time, gotten a little bit more complicated. What are your thoughts on billing, record keeping, how the process has become more complicated with the advent of computers? Is it a good thing or is it a bad thing?
So I think in general that using the computer, be it for the EMR or for billing, is important, super important for billing, because the old days, I didn't write down how much I collected from the patient on that yellow piece of paper, but I had a separate ledger card with the date of service, and if they paid me or they still owed me money. When a patient came in, you, of course, pulled out the ledger card to see that they still owe you money. And if they did, Mrs. Smith, you have a balance of $10. Would you like to pay that in check or cash and eventually credit card? Certainly for note-taking, that changed dramatically as we expanded from the LOM amox to really give part of the history in your notes, to talk about the physical, be it a normal component of the physical or an abnormal component. And although I'm a very fast typist, so I know most of us talk about when EMRs came, our volume went down by 25%. I didn't find that as much because I am a very fast typist, but I still had to log into the computer, go from page to page of the computer to find what I wanted to do. So it did slow down a little bit, but certainly medical legally, if you're taking good notes, which is what you must do, you really have to document what you've done. It's a lifesaver, and it ties into coding. Because if I'm using a code and the insurance company questions, why did I use that? The documentation is there. It's easy for them to see as well.
Right. I have a question for you, because I was a kid in the 1970s. What would $18 buy you? Was that a lot of money, a little bit amount of money? I can tell my dad bought his first house for $100,000 in a nice suburb of the Washington, D.C. area. But I don't know what $18, that was in 77. I don't know what $18 was in the 1970s.
So I'm trying to remember back then. I think back then an ice cream cone was maybe $1 and change. So we could have a lot of ice cream. And obviously, what you paid for your home depended on the type of neighborhood. My wife and I bought our first home in 19, lovely community. We wanted to live somewhere else, but I just started practicing. We couldn't afford to live in a different community. It was a very nice one, but not where we wanted to live initially. But I don't remember what it cost. If you went to a hamburger, maybe it was $2 and change.
Okay. So maybe taking the whole family out to a hamburger joint.
Probably, yes. But you're asking an old man now who can't remember what he had for dinner last night. So I'm sorry.
I have no idea. I was alive back there, but I never paid anything. My dad paid everything.
Of course.
I don't know what, I can't even tell you. I remember helping him put gas in the station wagon, but I had no idea how much the gas cost.
That was 25 cents a gallon.
Yeah.
I can remember in 1979, we had the big oil crunch. Actually, it was earlier with the shortage, and you lined up.
Right.
Take you an hour to get in. So I was a resident, and I would wear my white lab coat, and they would see me and say, "Okay, Doc, come on, come to the front of the line." And I think it was like a quarter a gallon back then.
Yeah.
That was some of the perks of being a physician. That happened also during Hurricane Sandy with the gas out here on Long Island.
That was for people who don't remember that, those were the Carter years, and the children's and the homemakers, the wives, because my mom was lucky enough that my dad made enough money she could stay home if she wanted to. We had 2 cars, and so my dad would go off to work, and then the other car, mom and the kids would stand in line for hours at the gas station until you could fill it up, and then they would trade cars. That was a very different experience.
Yeah. So tell us a little bit about your day-to-day medical life in the office. What kind of cases did you see compared to what we have today?
So back then, a lot of this infectious diseases. You have to remember that the vaccines like polio, DPT, and measles and mumps and rubella, they weren't widely accepted back then. Some of them were relatively new. I don't remember people saying no to them the way they do now. Well, I can tell you for myself, when I was a little kid, I was born in 1949. In the early 50s, my mother wouldn't take my brother and I to the pool during the summer because polio was rampant and we had the iron lungs. People were deathly afraid of it until polio vaccine came out. So it was lots of infectious diseases, otitis media, tonsillitis. I still remember giving IM injections of bicillin per kid who had strep throat. I remember the last one I ever gave was in July of 78 because it hurt so much.
Yeah,
That was what you were seeing.
For those of you who've never given bicillin looks like milk. It's this white thing, and it hurts tough shot to take.
Remember those kids that used to have rheumatic heart disease that would come in once a month for the bicillin?
Yeah.
Back in those days, it was very little mental health. I don't think I even knew what autism was back in the 70s. Certainly, you weren't looking for treating depression and anxiety. Temper tantrums, you talk about toilet training. But with the illnesses, it really was infectious diseases and the asthmatics. Treating asthmatics back then was really difficult. You didn't have any of the meds that we do today called the inhalers. I remember the first time trying to give a steroid, we had the something like Flonase, and we would put adapters on the Flonase bottle so kids could inhale it. Theophylline was the big thing, but you had to be careful. Someone to theophylline toxicity, and I remember in the office doing theophylline levels in the office because you had a narrow range where you could be at. So we thought we were good then, and we had lots of things to help our patients. Doesn't compare to today, though.
Yeah,
but even
I guess with all these illnesses, acute illnesses, and no progress notes, I guess you could see what they would call 40, 50 patients a day, right? Back then.
I don't think I was seeing 40 or 50 patients back then a day. Certainly later on in my life, before I started taking people, and physically it was too demanding.
Right.
I couldn't do that. I wasn't putting it in a 7-hour day. I was putting in 10-hour days to see that many patients, which is why I said, okay, well, you better bring someone in with you.
And back to the asthma, did you give epinephrine shots for asthma?
We called it adrenaline. We called it adrenaline sub-Q back then.
It's awful. I had that as a kid. It's awful.
Yeah, but you had it as a kid, thank goodness, because if not, you might not have made it to the ED.
No, I know, but it was just awful. And then we did used to mix Decadron in the nebulizer and atropine in the nebulizer because there was no budesonide. And that was true until the late 80s, early 90s.
I can remember back in the 70s, admitting asthmatics left and right to the hospital. Because there they would use continuous theophylline drips, not just the oral stuff I could give in the office. I can remember when I was chief resident, our director, the chairman of the department was really great. And he took one of the big rooms, because we still had wards back then. He converted it into an ICU unit for peds. We had someone who had done 2 years of peds and 2 years of anesthesiology. And he sent her down to Philadelphia. I don't remember the doctor's name, to train there, to learn about an intensive care unit. And she came back and she ran this little 4-bed unit that we had. And even as chief resident, we were, oh my God, you're going to do what to this patient? It's, to me, miraculous, the changes that we've seen. Certain vaccines, I think it's the greatest thing in pediatrics ever, because I see how many lives we saved, how many lives we lost back then. And I lost patients in my practice from some of the infectious diseases.
Paul Offit says that the vaccine schedule that we have now have extended life expectancy of the U.S. population by about 30 years, which is amazing. It's not just helped the kid that didn't get meningitis and died, it's helped everybody. And then you must have been practicing, I remember, because I have a sister that's 16 years younger than me, when the pharmaceutical companies stopped making vaccines because of litigation.
That's funny. I don't remember that. I never remember there being a shortage of vaccines in the 70s or 80s, the 90s. Quite honestly, I don't remember that at all. Always got our vaccines. It was never an issue, never ran out. The companies were good. Obviously, when there were a group of us who we had these ped pharma councils, about 10 or 12 of us were around the country who came together. I was approached by one of the major vaccine companies to bring people together, and then the others asked to have their own sessions where we sat down and talked with them. The fact that today you get a discount if you pay for your vaccines within the first 30 days, that came from our group. We really made an impact. I know one person who became a vice president of one of these huge international companies credited us for getting them that advancement because they liked the input we gave him. And it was good common sense. It was good for the patient. It was good for us.
Yeah. No, I do remember because my youngest sister is now a lawyer and she lives in New Jersey. She couldn't get her child, like DPT and polio because the pediatrician downtown in DC couldn't get it. And that's where they created this special court for vaccine litigation and the victim forms and all of that. I
never knew that.
I thought it was the pediatricians got tired of not getting paid, but it was, they were being sued. Merck was being sued. And they were like, we don't make that much money off of polio vaccines. And we manufacture them. There's no patent on polio vaccines. If we keep getting sued, we can't afford to do this anymore. And that's where the Vaccine Liability Act came about, which has allowed them to produce these very good drugs without the fear of getting bogged down in thousands of litigation.
Yeah, but today the vaccine, back then, I think the vaccines were what, $3, $4 a dose?
Yeah.
Now they're $300, $400 a dose. That's a lot.
Yeah, but again, a house in a nice neighborhood in the 70s in Montgomery County, where my dad bought his house, is one of the nicest counties in the DC metro area. You could buy a 4-bedroom house with a 1-car garage, great schools for $100,000 in the late 70s. Today, that house, you can't get into a house in that neighborhood for less than $1 million. You can't compare $2 back in 1970 to $400 today. Inflation takes a toll, and the cost of doing these things takes a toll.
You're right on that. So I guess things have changed. Things have changed in the examination room, in the office, and everything. We went from treating acute care injuries. Now we're more into chronic care conditions that take a long time for the physician to deal with. Obesity, behavioral health, anxiety, depression, ADHD. Pediatricians in general want to provide high quality care. But how can they do that and still stay in business? What do you think?
ADHD, what is that? Never heard of it before.
The thing that every other kid has.
For me, learning disabilities, ADHD has been I call it a subspecialty interest of mine. I had my own child study team where we evaluated kids for school systems as well as privately. Things have certainly changed. You still have your common illnesses. You still have to worry the occasional scare if a kid comes in with a stiff neck and 103 degrees and, oh my God, could this be meningitis? I haven't seen it for years. More and more, dealing with psychosocial issues in the practice. Obesity is absolutely horrible, but you can do it. Now, you need to spend more time with the patients in order to do this. And the question is, how do I get paid for that time? So as we all know, CPT coding has been around 35, 40 years in this country. It's evolved tremendously. Back in the late 80s, the AAP nationally asked for volunteers from every state chapter to come and learn about this new CPT thing. And the codes then, there were, I don't know, a handful of codes that we were all supposed to use back then.
Mm-hmm.
For me personally, I'll just tell you a quick story. I was a young man going to my New Jersey chapter meeting. I wanted to get involved. It was a night meeting. I was tired. I had 2 kids. I actually fell asleep at the table, and the president of our chapter had just asked for a volunteer to go learn about the CPT thing. My friend said my elbow fell off the table. My hand shot up, and the president said, "Richard, thanks for volunteering." True story. The best thing that happened to me. Coding helps us because it tells the insurance company, I've done X, Y, and Z. I contracted with you to be paid this number of dollars for this code. I want to be paid. Now, of course, the insurance companies fight us tooth and nail. Some of them don't accept CPT coding, although we physicians must use them. We've got to go by CPT rules, but the insurance companies don't. And that's why the academy on the national level has really been fighting for us for 20, 25 years. There was a time when the academy could not talk about the business of medicine. I know in my state, usually it would be the president of the chapter and some other people had formed a separate group in our state to try to discuss with the insurance companies. We couldn't do it through the AEP. And that fortunately changed for us probably late 80s, early 90s. And that's where you've got SOPM, which is the business arm of the academy. We had PAT, which actually can talk to the insurance companies about problems that you in Long Island are having, or someone in Des Moines, Iowa is having. We have the hassle factor for, which hopefully everyone knows about. You're having a problem with a company, fill it out, send it in to the academy, and someone from the academy will take care of it. In the old days, if you complained to an insurance company, oh, you know what, I'm having an issue with this code, and they would say, Randy, you're the only one.
Yeah.
But now, if you can show them 100, 200, 500 people around the country, they can't say that anymore. So to me, the academy has really worked hard to help us. Coding is a pain. Unfortunately, I've got my own consulting business, and it's still going all these years because a lot of our colleagues still don't know how to code properly, don't know how to document their notes properly. And when they're audited, they're getting nailed, and insurance companies are saying, all right, you made a mistake here and there. So we think of your 10,99214, so you made a mistake. All right, please, you owe us $100,000 back because we downcoded you. It's terrible. Codes change every year, the CPT codes as well as the ICD-10 codes. But come on, there are people, George, who still don't understand the basics. If a kid came in for a flu vaccine, besides billing for the vaccine and the vaccine administration code, they're putting it in office visit when they didn't do anything. And they want to know, why am I in trouble? So you need to know, you need to have the code, and the state chapters, national, all have new codes are always coming out. You need to know how to use them properly. And you mentioned behavioral healthcare and care coordination. People will be shocked how many codes there are under care coordination and chronic care management. You have to know about them. You have to know the differences between each code. But there's so many, and so many where it doesn't have to be the doctor who's doing the work. It could be someone else in your office who's qualified to do it.
This episode is sponsored by our friends over at Freed AI Medical Scribes. Let's hear what they have to say. What if you could take the computer out of the physician-patient relationship? With Freed, you can
Freed is the AI medical scribe that listens, transcribes, and crafts perfect SOAP notes for you seamlessly. This isn't just another productivity tool. Freed is a life-altering solution for physicians, helping you regain the joy of practicing medicine. Freed frees you from the burden of documentation, so you can focus on what really matters, your patients. With Freed, the computer is no longer a barrier. It's a quiet assistant that works in the background, capturing every word of your patient interactions, accurately and quickly. The result, you're fully present in each visit, building stronger connections and offering more attentive care. And when the day is done, your notes are too, leaving you with more time to focus on yourself, your family, and your life outside of medicine. Freed is the solution thousands of physicians swear by to reclaim their passion for medicine. So let me dig a little deeper to that, because you said a lot of things. And I wish it was as easy as you're describing to do these things. First, there's a big, steep learning curve, because these codes keep getting generated. I don't know how many codes are into CPT today and makes, but there is hundreds, if not millions, of codes, which makes it a challenge to keep up, even if you listen to your talks and you read and you try to stay up to date. Then there's they don't make it easy. So the care coordination codes, an office staff member, the secretary, the front desk person can do the care coordination. Doesn't have to be any kind of license. And there's 3 types. There is one for when the physician does it, one for when the physician does it and the patient only has one chronic disease, one for when the physician does it and there's 2 chronic diseases, one for when the staff does it and there's 1 chronic disease versus 2 chronic diseases, and those are in 20-minute incremental steps, but they're to build only once a month. So just the record keeping of my care coordinator is reaching out to George's son about his asthma, making sure that he's taking the inhalers properly, notes it in the chart. She or he has to put it down somewhere, and at the end of the month, make sure that goes to the biller so it gets charged. That doesn't make it easy. Then you have to go into each state's different Medicaid web portal and figure out how they're playing the system. So in Virginia, they have a wonderful program started by Sandy Chung, where I can call a pediatric psychiatrist through VMAP any day of the week for a kid that I am at a loss to what to do with their mental illness. And they're very good. They'll call you within a couple hours. Virginia Medicaid has decided that because I'm doing the care coordination, talking to that psychiatrist who's on a grant, so he's not getting, or she's not getting paid through insurance, it's a grant for their time. For that time, that hour I spent presenting the case, going over the case with a psychiatrist on the phone, trying to coordinate care for this patient, Virginia Medicaid says that work is worth 0. It's not uploaded, so nobody will pay for it. If you, for 1 chronic disease in Virginia, Medicaid decides that's not worth paying for. So if you only have asthma and I'm trying to keep you in school, out of the emergency room, through whatever intervention we're trying to do, forget it. Not going to work. And Virginia Medicaid won't pay for it. G2211, Virginia Medicaid won't pay for it. The other one that I just recently looked into was remote patient monitoring, because that makes sense to me. What you measure improves. So if I can get a child who is overweight or obese, hopefully overweight, and I can start getting him or her to weigh themselves at home once a week, and that is coming into the computer system, and someone in my office is looking to see if they're gaining weight, maintaining the weight, or losing weight, and reaching out to them and saying, great, you lost a pound in the last 2 weeks. That's awesome. That I think could make a difference in that child not ending up with a BMI of 35 or 40 and then type 2 diabetes and hypertensive. Virginia Medicaid does not consider obesity a chronic disease. And if you have asthma and you want to do remote monitoring in Virginia on the children, they have to have had 2 ER visits within the last 6 months in order for them to pay for the remote monitoring. So it's, and to your point, I was going to ask you this question too. I only do per diems, but the practice I help is a solo pediatrician. She's been there for 25 years. And my idea is when I see a well child exam, if they have obesity or depression, that's why we're screening, we address the problem. So you put the 25 modifier and a 99214 on the bill because it takes time. That's not part of the well child exam. She got a letter from Anthem Blue Cross Blue Shield that has over 40% of the business in the country saying, you're seeing too many 25 modifiers with your well visits. Stop it. So now I do what really irks me, which is I make sure that BMI is reported so United Healthcare and Anthem Blue Cross Blue Shield of Virginia can charge the state of Virginia more because these are more complicated patients. The child gets no care and the pediatrician goes and sucks in a lollipop. So it's, and then you're like, why do I even bother? Why do I even listen to Dr. Lander? I know that if they got depression, they screened in, I should cancel the kid and I should charge for that time. That's not part of the well child exam. But if I do, they're going to wrap my knuckles.
There were solutions. So disagree with you. So I was in private practice up until 3.5 years ago. I retired. And after 2 weeks, I went to my wife. Oh my God, I can't do this. I've got to work. So a friend of mine had 3 offices. And I said, do you want some part-time help? He said, great. So Medicaid practice. So for me, we had very little Medicaid where I practiced before. Overwhelmingly, 90% of all the patients I'm seeing now are Medicaid. And my attitude is the same as yours. So someone comes in for a well visit and they're obese, I need to address them.
All right.
Doesn't take as much time though. And I have what I do with my own patients who are obese, but I want them to do and come back. ADHD. I had a 16-year-old girl last week, nice young lady. And she's got a GPA of 3.1. We do the pH to look at her. And I'm seeing she can't concentrate. She feels bad about herself, et cetera, et cetera. So I started asking questions and yes, she can't concentrate. She's impulsive. She's forgetful. She can't stay on task. And I looked at the mother. I said, you know what? I really don't want to do the well visit today. This is very important. We need to discuss this and we'll reschedule you for your well visit, which the mom said yes, because that's much more important to take care of than signing the form that they want. So come back in 2 weeks when I have an opening. But the other thing for what you said earlier, yeah, Medicaid is a pain. Absolutely a pain in the neck all over the country. A lot of the things that you said, you don't use the CPT codes for chronic care or care coordination. Time. You know that all of our CPT codes from the 99211 up to the 99205, there were times for each one of them. So if you have a kid who came in who is, you think, depressed, okay, and you did PHQ-9 in it or some other vehicle, and you're talking to them, and it's a known diagnosis, and they're coming back to you once a week, once a month. On those visits, bill it by time. Don't use the care coordination or the chronic care codes. You're going to get paid for that. Now, there might be RVUs in those other codes. Again, I don't remember how many RVUs there are for 99214, which is a 40-minute visit versus using something for chronic care, but you're going to get paid. So I might not get paid. I'll make up a number, $100 for that visit. I could pay $80. So am I losing a little bit? Yes, but still I'm doing what I need to do to help my patient because that's where I wanted to be. I'm happy, made a nice living as a pediatrician, but I love what I do and I love helping the kids. You're right, make a little bit less money. Some people try to make it up in volume, see more patients in the day, but then they're working harder. My consulting company, we say you want to work smarter, not harder. But if this is what's been happening, but you're telling me in your own practice, start billing by time. And remember, it doesn't have to be contiguous. So if you looked at someone's records in the morning and then discuss something with them later in the day, the time adds up together. You'd be surprised
But that's in a 24-hour period. That's in a 24-hour period. So
no, not 24, the date of service.
Right. It's from 01 of today's date till
11:59. Right.
11:59. if the psychiatrist or the cardiologist calls me tomorrow, I can't tag on that to today's visit. Based
No,
on
but
this.
there are codes which Medicaid might not pay for, where you're communicating with a physician
Right,
about
right.
your patient.
And that's my point. The codes are there. You can go learn them. And then the payers and Medicaid said, no, we're not paying for that.
Within this advocacy, and that's what the AEP is there for, be it your state chapter or national. These are things that our AEP has to take up and challenge the payers, be it commercial or Medicaid. When I was chair of PAC, we were only 6 members. Each of us took a major insurer, Cigna, United, the Blues, whatever. And just before my 4-year term ended, I convinced the board, the academy, that we have to go after Medicaid. And they added several more people to the committee to cover Medicaid. So we are making inroads, but we can't keep fighting. We can't stop fighting, because if we do, they'll just take things back. But we have to keep them on their toes. We just have to go public. When I was chapter president, I personally wanted to sue our Medicaid chapter, our Medicaid in our state of New Jersey, for things that were wrong. The Pennsylvania chapter did it. I'm going to go back 25 years. And they won. Now, granted, Medicaid didn't want to talk to them. Yeah.
Florida did, and they won. They got a great settlement.
And then
I don't know where they got the money to sue them from, but they did.
So,
And
I'm just saying about,
when you look through your consulting company, what is a good ratio of 99213s to 99214s in a general pediatric office?
So it changed. When the CPT rules changed in 2021, to where we now have either use time or medical decision-making, which is made up of data, number complexity of problems, and risk, it changed. I was a big 214 user previous to that. Easily 64% of my sick visits were 4s. Not because my patients were so complex, but I took my detailed histories and I documented it. I took my physical and I documented it. I was audited multiple times going back into the 90s by all the insurance companies, but they never paid a penny back to them because my documentation supported my use of whatever CPT code it was. And I didn't document to get to that code. It was just me trying to be thorough. And back in those days, that counted. That changed substantially. And now I think I have more 3s than I do 4s. I have found consulting for practice around the country, when I do charts for them, they're usually wrong. The doctors either undercode, sometimes they'll overcode. When they've been audited by insurance companies, be it commercial or Medicaid, those audits by the insurance company are wrong easily 20% of the time. I had a practice in Connecticut come to me about 5 years ago. Medicaid Connecticut was going crazy going after pediatricians. Large practice, they audited them. They wanted $600,000 back.
wow.
I reviewed the charts, and Medicaid was right, 80%. So they wound up paying a challenge. So they didn't pay $600,000. So instead they paid about, let's say, $450,000. It's a lot of money because that documentation was terrible. Their 4s weren't 4s, they were 3s. So I'm finding more and more. I would say it's probably 50-50. I just did an audit 3 weeks ago for a 3-person practice. It was pretty much even how many times they undercoded versus how many times they overcoded. It's documentation. Listen, I hope we're all had residency training. We all do the best for the kids, and we try to do what we have to. But if you don't document what you did in the chart, you're lost.
Yeah, but this is where the problem comes in. How do you do volume to make up for loss in reimbursement? Continue to do the right thing, as Herb said. Seeing a patient for I don't agree with you on this, where you say seeing a patient for a checkup and they come in and they're suicidal or whatever, anxiety, depression. You say, okay, we're not going to do your checkup today. Come back next week, because there's other factors involved in this. There's quality incentive programs that require you to have a checkup. So there's funds attached to that. So you've got them in for their checkup. You might as well finish it. I've had cases when a teenage girl came in for a checkup. She filled out the PHQ-9 and she was suicidal.
Yeah, everybody had cases like that.
Yeah. So what my process is, I do the checkup, I order the stuff, then I start entertaining the PHQ-9, talk to the mother, talk to the kid, and then send them to wherever they need to go. If they're suicidal, they're going to the ER. But you should be reimbursing this because they're not just a 10-year-old that came in for a Tdap.
You're right. That's the key word, George, should be.
Yeah.
And with the commercials, you can get away with more using a 25 modifier
Right.
than you can with Medicaid.
Yeah, but this coming around, and there used to be advocacy on this where it wasn't paid before. Then it was okay as long as you had documentations. The EHRs developed process where it's easy to document because there's always a documentation. You never wanted to write another note. But now it's easy to write another note. So they should reimburse or pay Dr. Bravo. They should. And if somebody has to advocate this.
But that's the AAP. That's who to advocate, because that's the power of 66,000 pediatricians. But you listen, you and I all know, particularly with commercial, Pediatrics is budget us to them.
I know that.
But it's significant to us. So that's why we have to fight, which means we have to push our chapters to do it. We have to push national to do it.
So the problem is that this is how the insurance companies work. So if you're RBK Pediatrics is a large company, has a lot of revenue. If I'm going to pick United Healthcare, writes him a letter, says, Dr. Rogu, there's too many ENF codes 25 attached to your oral child exams. He'll write them a letter saying, F you, let's come look at my charts and we'll have a fight. But if you got a 1 or 2 person pediatric practice and Anthem Blue Cross Blue Shield is 40, 60% of your business, says, you're doing this too much, which is a veiled threat of we're going to audit you. And then that's going to mean I'm going to have to hire an attorney and I'm going to have to hire Dr. Ridge to come in and defend me. And that's going to cost money and time. And if they just say, no, they're just going to take it off the next paychecks, I'm going to stop doing it because it's the easiest thing to do. And then you're frustrated. And it's not just the catastrophic, the teen is suicidal or they want their asthma meds refilled at their well child exam, which drives me nuts because it's not just a prescription. What are you doing? Is the kid coughing? Is he not coughing at night? Are we on the right medications? It's not just an asthma plan for the school nurse. It's not just bureaucratic paperwork that I'm filling out. That's not what I'm getting paid for. I'm getting paid to make sure your kid is taking as little medicine as possible, because that's always the best, but enough so that they have a good quality of life and they don't end up with a bad outcome. And they're telling me, don't do that because we don't want to pay the extra bill. And then there's the pressure of the word that I really dislike, value-based care, which is basically if you report the BMI, you do the well child exam, and you keep the kid out of the emergency room, we'll share a little bit of all the money that the CEO of United Healthcare makes off of your work, doctor. And if you don't, you won't get paid. But don't bill us anymore for sick visits because we don't want our loss ratio to go up.
Mm-hmm.
Do the right thing because you're a pediatrician. That's what you're supposed to do. And pediatricians do the right thing.
The right thing is taking care of the patient, period.
Right.
And then it's fighting with the insurance companies. But again, one of the things that I talk about, conferences I talk about practice management and that CPT coding, get your patients behind you. We had here, AT&T had 22,000 employees in my geographical area, and their insurer was hassling us. So what did a bunch of us do? We put it out there to the patients. Go to HR. Tell them this is unacceptable, that my doctor, Dr. Land, or whoever it is going to drop because you're doing this, which is not right. So HR, we're paying you. We work for AT&T. We're your employees, but therefore you have to go and talk to company X. And it does work. The other thing is going public. I'm a big one on that. I think if people knew, the public knew more what was going on behind us and that we're not all rich doctors who do nothing. I got a call last night at midnight from a parent, horrible Kruger. I haven't seen Kruger for a while. The kid was really nasty. Am I getting paid for being woken up at midnight? No, but that's what I signed up to do, to take care of my patients.
You know what? They came up with this new thing called telemedicine. It seems to help. I don't know how much your experience is on it, but how do you think telemedicine plays into modern pediatrics? And how can practices bill effectively for this?
For as the CPT codes are the same ones you'd use if this to your established patients, 99211 to the 215, depending on your level of documentation or the time. I personally don't like telemedicine if someone says I got a fever of 104. No, you got to come in. I have to actually examine you. Now, I know that there are these new apps like looking in the ear. There's an app for that. Listening to the lungs. I personally don't have those. I guess it would be beneficial. But the fact of the matter is, I think it's fine, particularly when dealing with mental health and behavioral stuff. Our daughter's a child psychologist. 8 people work for her. They don't take insurance. I'm very proud of her. But she hated COVID when everything was all telemedicine, because it's more than just talking to the patient. It's looking at them as they're reacting. So telemedicine, you're seeing the face, but you're not seeing them fidgeting with their fingers or whatever else they might be doing. So is it okay to use? Yeah, I think you have to use it appropriately. ADHD? Sure, I'll use it. Do I still want to listen to the heart to make sure they didn't get tachycardia from their med? Yeah. Or that I can see the hands if it's trembling when I ask them to put it out. All right. So I think there is definitely a place for it. You have to still make time for it in your practice. Right. And you can't say to the patient, okay, we'll do it at 2:00, because you might get swamped and you're not there at 2. So you've got to set aside specific time for telemedicine, whether you're going to do it in the morning, you want to do it at your lunch break, you want to do it at 5:00. So not to interfere with what's going on in the office.
Yeah. What we did is I have to credit Carrie Firestein for this idea. She said, just put it in the doctor's schedule, just like an office visit. There's nobody can complain about it then.
Yeah.
But just unless your practice is very different than everyone else's, we almost never run on time. I'll apologize. If I come in 5 minutes late to a patient, I'll tell them. I know lots of people who are sitting in the doctor's offices for an hour waiting to be seen. So what's that person supposed to do is a 2:00 telemedicine with you, and you didn't call them until 3:00. Oh, 2:45, I've got to run out to pick up my kids to school.
Yeah, that does happen.
So I think RBK does a good job in that. They see the AD kids twice virtually and once in the office. So you get a blood pressure, a weight, you can see you're actually putting your hands on the kid. And I think an obesity might also work, right? I just need to know how you're weighing, how you're feeling. Are you going to the physical therapist? Did you meet with a nutritionist? There's not much I can really do. It's a heart rate on a skinny kid, or an overweight kid, or an obese kid. I guess I'm missing out on the blood pressure. Some of these kids already have high blood pressures. Where it doesn't work, the time doesn't work. The time billing doesn't work in Virginia, in particular with Medicaid. And some of the commercial payers are worse than Medicaid in the amount that they pay pediatricians. But it's just a simple math. If I can see 3 strep throats, and the 99214 in Virginia pays, I think, $90. And they take 10 minutes. So I made $300 worth of revenue, which is enough to pay the staff and pay myself something. If I spend 45 minutes with a depressed patient, that takes 45 minutes, and I'm doing it on time, that's $100.
Yeah.
If I do 5 of those a day, Dr. Sinha, who's the person that hires me, is going to say, Herb, I love you. You're doing a great job, but unfortunately, I can't afford to pay your hourly rate.
So Herb, you got to be careful though. Something you just said, you don't want to take a diagnosis and think it's automatically going to be a 4, because you can have a 99214. You can have a kid with strep throat without fever, and if you only did a rapid strep test, by data, you're at the 3 level. Using an antibiotic for risk is at a 4, but if it's an uncomplicated acute problem, you're at the 3 level. So I'll caution everyone there, don't take a diagnosis and say this is always a 4. Now the kid had fever.
Then it changes. But
Infectious.
I'm giving you an example, right? You could do doing 5 colds at $60, which is what Medicaid pays. You could get $300. If you do 1 45-minute consult, you get $100.
Yeah, it's terrible.
So you
Yeah.
can't. So yes, I can use time, but time works against me because I'm not getting paid enough for that complex patient. And that's not the CPT code's fault. I'm just saying it's so difficult to be able to do what I think we should be doing as pediatricians, which is having the space for the acute care kid that got the bellyache or the sore throat or started wheezing, doing the chronic disease management and still doing the well child exams and being able to run on time and be paid enough so that I can pay the people that support my practice
Right.
enough, the front desk person, the billers, the medical assistant, and I can still make a pretty decent salary.
Could you, the mental health, okay, what you talked about? So is
Yeah.
you spend 45 minutes and you got $100. People, the psychologists, psychiatrists who participate with the insurance companies, it's disgusting how poorly they are paid based on the time. And so I'm very proud of my daughter. She doesn't take insurance and she's got a lot of people who work for her. She's very good, so that helps. But for us, yeah, it's terrible. And that's why I know that the Academy is trying to work on parity for mental health issues. So if we have a 99214, which I'll say is for us, the people in mental health, you've got to look at them and saying, this is all you have is your time. I want good people seeing my patients. And I'm sure you, like everyone else, has trouble finding good people in mental health to take care of our patients that we're happy with. There are loads of people who participate with the insurance companies, but they're usually different, unless they're really altruistic and they're not interested in the money and they're happy to see Medicaid patients because they're happy taking care of kids. And if I don't make $100,000, all right, I'll live on $60,000. But there aren't a lot of them around.
Yeah, but most of the psychologists in these programs are funded by hospital systems. They usually have a grant that covers it. And once the grant goes away, so does that department. Seen it happen.
Yeah, but you could do, we all know Gail Schoenfeld in Long Island, Jeannie Marconi, who was in Connecticut, who had people in their practice doing it. And then it comes down to how do you split your profits with people? So many years ago, I won't mention the hospital system, was asked by a large pediatric hospital system to evaluate all their docs. And we looked at the RVUs, and one doctor was so much lower than everybody else. Turned out she was doing all of these complicated mental health issues, developmental issues. So the way they made it up to her wasn't just based on RVUs, because she was getting nailed. She did it that way. They understood that by allowing one person in the practice to deal with these issues, it freed up the rest of them to do 5 or 6 visits in an hour. So they were more than happy to share some of that revenue with the person who is doing all of the behavioral and mental health issues.
Yeah, I agree with you on that. But the truth of the matter is, people pay a lot of money for their insurance, should pay for services. Simple as that. And if they don't, we need some force or some club that has a lot of people behind them to advocate and to help. I don't want to say this, but all I hear is we're going towards this Medicaid for all children. All children should have Medicaid. That's a problem. You can put pediatricians out of business, I think, with $54 office visits.
I agree with you. I think what's important for us to remember that there is strength in our numbers.
Mm-hmm.
I'll go back to the early 90s. We had seen what managed care had done from on the West Coast coming across the country to us. And Prudential, which was a big player in our area back then, there was capitation, and it was terrible. A lot of people had already signed up for it in different states, including New Jersey. But we had two geographical areas that were contiguous, and we stood up. We said, no, we're not taking what you're offering to us. this is what we want. And if you don't do it, we have too many pediatricians who won't do it. How are you going to sell your insurance here? Because our pediatricians take care of the company. We held up a tri-state contract for the company, Prudential at the time, until we got better rates. They even brought in, we found out his nickname was the killer, because they would bring him in from wherever he had to go in the country to beat the heck out of doctors. So they would just do what the company wanted him to do. We stood up and we got better rates than other people. So
you negotiator. You're a good negotiator and you're scary.
Come on, look at this.
You are. Most pediatricians are not scary.
I think your point, Dr. Lander, is very well taken, which is I love pediatricians. I think pediatricians are some of the smartest physicians in the world. And there's only 1 million physicians in all of America. So you're already at more than 99.95% of the curve, right? But we like to complain and we don't like to take action. And the actions, as you said before, they're called mothers and grandmothers. If every time that you have a patient in your office, whatever the insurance is, and they can't get an appointment with the behavioral pediatricians because it's a 2-year wait, or the pediatric endocrinologist is a 9-month wait, they can't find a decent CBT psychologist that takes their insurance plan, and the psychologist was $300 an hour for therapy. And you had a little form. I live in Virginia, so it's Mike Warner and Tim King. That mother wrote a letter to Mark Warner and Tim King while they're in your office, put their name and their address so they know that they are voters for them. You sure would see a change in the way that they think, because now all these dumbass politicians on both sides of the aisle care about the soccer mom, the ex-suburbs mom, the grandmother. Women have a tremendous amount of power because they win elections. And when women start complaining to their elected officials, the elected officials don't like it. And they want to get rid of the problem because they want to be reelected. When the three of us show up with a Mickey Mouse march advocacy thing the AAP does, and we parade like a bunch of clowns through the Capitol Hill, they're like, "Hi, good to meet you. Great. Thank you for your service, Dr. Bravo. You're great for being a pediatrician. Move on." But if we all collectively, every time a mother has to struggle with access to a subspecialist and their kid has to wait without care, writes a letter to their elected officials, boy, you would see a lot of change and very fast. We don't do it. We don't organize.
No, but the kid do it. I know we did it where I am. I've done it in my own practice where I've had my patients write letters. So it's up to us to take that initiative. You mentioned you're getting nailed. I don't know if you read in the paper the other day, Medicare is decreasing by 2.5% what they're paying. My son's an adult cardiologist, so loads of his patients are Medicare. Directly going to affect him and therefore my grandchildren.
Yeah.
Yes, we have to advocate. And I'll disagree with you that walking around DC with several hundred pediatricians, it gets noted, but much more importantly is that you and me and George and everyone listening take this to heart. And when there are issues like this, reach out in your practice. Have the people know what's going on and let them know if this keeps going, I can't be here anymore. That you don't want to use money because they're going to say, oh, all they want is money. I won't be able to give you the care that you used to because I'm not going to be able to do it because the government is demanding more and more of me and time I've got to spend because of the insurance companies outside of just seeing you. And like, obviously the cost in the old days, how many bills did you have? It's different now because you need to have people to bill it. Got to make sure that you've been paid appropriately. You've got to be able to appeal a denial. You have to be able to reappeal the second denial. New Jersey has something where it's an executive appeal. And the medical director of that insurance company has to get back to you as an individual. I forget if it's 3 days or 5 days. So, yeah, we've got to push our lawmakers, but it's up to you won't do it and I won't do it. when I was just me in solo practice and I had a problem, I wouldn't get a call back. It could take a month or two. When I was chapter president, oh yeah, like I could get a call back in 48 hours. When I rose in the ranks of the national, boy, within hours, I could call up the CMO of any major insurance company, let them know my title, and they called me back right away. So we have to.
What was your title? What was your title?
So, for instance, when I was just a member of PAC, we used to be PPAC, and I always chose United because I just liked them so much. I called them the evil empire. I could call any medical director in any state and tell them I'm calling from the National AEP committee that deals with insurance companies. When I was chair, I skipped all that. I went right to the CMO. And I've got to tell you, a lot of the CMOs were not just doctors in suits. They still remembered it. And I had a lot of help from the CMO nationally. I'll even use United. The guy that I interacted with was great, but you got to take the time out. So I wasn't seeing patients. I was on the phone quoting the insurance companies.
Right. You know what?
I think
all the
I
time.
think your point. I
I'm
think
a
your
member of
point.
PAC, which you have to get approval. So I always go as George Rogel from RBK. I never use my
I
title.
think to your point, you're absolutely right. If you get the parents involved and you cannot tell the story, there's two things you can't do. Because when you talk to lawmakers, first of all, not because they're dumb, it's because if you're a congressman or congresswoman from West Virginia, you have 1,000 different issues that are important to the people that elected you. And you just don't have time to know how much is the pediatrician getting paid for an ear infection in West Virginia. They just don't have the bandwidth. And so you have to educate them and say, this is why it's a problem. If you don't go with a solution, they're like, I have a very small staff. I don't have a think tank. Bring me a solution. And three, as you said, don't make it just about the money. Tell the story of all these kids who are not getting care because the system does not pay for their care. And in the long run, that's costing more money, and we're wasting wonderful lives that have huge potential and impact just because we don't want to spend a little bit to make the system work for the kids. But if you go in there, my salary is not enough, they're like, neither is mine.
Okay.
I'm a congressman. The average pediatrician makes $200,000 a year. I make $180,000, and I got to pay for plane tickets back home every weekend to see my kids and my wife. And I live in a townhouse with 4 other Congress people so that we can afford the rent here. I don't have any pity for you that you want to make $300,000.
So you don't talk about the money. So the 25 modifier that you first talked about earlier, George,
Right.
New Jersey, our chapter, we got that started. It was with a company named HealthNet, because we, as a chapter, talked to them, gave them all the reasons why it was important to not just take care of problem A, but also problem B when it came out. So it does make a difference. So it's a multi-pronged approach.
Mhm.
Yes, Herbie, politically, we have to let them know what's going on. AEP does have a whole Washington office that does that, but it's still on the state level. The state level, you have to do it. And it's not just the politicians. On the state level, I don't know if you got a pediatric council of Virginia, they've got to be active. They have to really meet with the insurers, but we always didn't. Massachusetts was the first pediatric council in the country. I stole their idea when I was chapter president. We were just number 2. We would meet every 3 months with a bunch of the insurers, and we would talk about not necessarily only payment issues, but other issues like we have to do something about obesity in our state. We have to do something about lead poisonings. We had one insurance company who was fined $250,000 by the state for their poor performance on lead screening. We said to them, pay the pediatricians $10 to do the lead test in the office, and your problem goes away. And they did. So you've got to be able to not be afraid of the insurers. You've got to go toe to toe with them.
Right.
It's a multi-pronged approach to get what we need.
There needs to be leadership. Who is the leadership?
You, George, you're on PAC right now. You're a leader.
Unfortunately, the council in Virginia, the person's very well meaning, very smart, but this is a problem across all of the AAP Chicago and all of the state chapters. These are volunteer physicians. So people are seeing their full load of patients 4 days, 5 days a week. And then they're trying to find time to still see their kids, still see their friends, and still do this advocacy for free. And that's a tough ask in the complicated world we live in. I know I'm in the minority, but I told Dr. Jesse Hackle, these have to be paid positions so people can take a whole day off from their clinical load and do this work because it's really important. And he doesn't feel like that. He feels that it's our obligation to give back. But if you want the younger doctors to be involved that are not making that much money in pediatrics and they still need to pay bills, we need to pay for this time. We're in a tough place. And it's very interesting that you mentioned United Healthcare, the Evil Empire, because like you, I share a strong dislike for the way they do things. But they're not meeting their HIDIS measures on lead screening in Virginia because they pay LabCorp requests on a capitated basis.
Mhm.
So there are no lead screens or hemoglobin tests done, no HemoQs or child exams in Virginia. They all have to go to LabCorp.
And they never go.
And so they don't go. So you know what their solution is? They now sent, oh, by the way, we're going to send you a card, like the newborn screen card, right? Would you just do a finger stick on the kid, blot the blood on the card, and mail it back so we can get this done? And I'm like, to the owner of the practice, really? Are they paying you for the capillary blood draw? No, that's zero reimbursement. Are they paying you the $99000 for handling the specimen and mailing it? No, zero. You know what? Keep sending them to the lab. I don't care if they make their HIDIS measure and they make an extra buck for this or not. Not my problem.
Yeah.
So I agree with you that we can say no to the insurers. And if they come back and yell and scream and we're going to drop you, go ahead. Drop enough of us in my area, you will be able to sell insurance here. You've got to be able to have enough people. It's only 10% that you would need in any given geographical area to say no to them, to make them sit up and listen and change the way they do things.
But you also get these top-down heavy recommendations that independent pediatricians are supposed to implement. They're good medically, like the ACEs, the SDOH, MCHATs, PHQ-9, depression, suicide screens. It takes time. It takes resources.
It does.
And many times they're not covered.
It's a problem that I know I personally had brought up, and with Bright Futures, I was on a panel once, and I won't say which of their Bright Future people were there, but that individual talked to me for 3 years afterwards because I said, these are great things. I know it's for the betterment of our patients, but we need to be paid for this. It's our time. And this person, very altruistic, said, no, it's a responsibility we have. Yeah, it is, but there's only so much time in a day. And I'm not getting paid for this. Am I going to shortchange someone else in time? Yes, we've gone back to the national to say, before you come up with a recommendation in the future, and this has to be 12, 15 years ago, you got to think of the financial implications to the pediatrician in the office seeing the patient. You can't just say, do this, but it's the right thing to do. We need to be paid appropriately. And maybe it's $5 for it. I don't care.
And these things are not even big ticket items. They're $10, $5,
They will-
$8, but there's a lot of technology, a lot of resources, a lot of moving parts. So ACEs is a good thing. Nobody.
Yes, but again, I guess, and you two are far smarter than I am and done a lot more work than I have done on these issues. But I guess the conversation needs to change from us, which is, let's say the PHQ-9, which is almost universally not paid by Medicaid when you screen the kids. And you can't make it up on time because it's done at a well child exam. So there's no upcoding. That's time I spent really.
God forbid it's positive.
But if we just complain that we don't get paid for doing PHQ-9s, people are like, blah, 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 blah. But then when you say, unfortunately, in the US, in certain age brackets, the number one cause of death is death by suicide. it can be prevented if your pediatrician can do a quick screening that can cost $5 to $10. How much is your child's life worth? How much is your neighbor's child's life worth? How much is your child's friend's life worth in middle school who just died by suicide simply because United Healthcare rather pay their CEO billions than paying $10 to prevent a death?
That's getting the word out and educating people as to why we have our issues. You mentioned United. I don't know if you remember the name Bill McGuire. He was one of the CEOs going back maybe a good 20 years ago for United.
Doctor. He was a doctor.
He was a pulmonologist, and he got, when his golden parachute, you remember how much it was?
$1 billion of backdated stock options that they clawed back.
No, okay. $1.5 billion. They only clawed back $0.5 billion. He still walked away with $1 billion over 20 years ago.
And that's
for
not
what
his,
reason?
for fraud. He got caught for fraud. That's
Yeah,
why
I
it's
mean,
hard.
So the
But
fact of the
not-
matter is, it's the insurance companies have to police themselves as well. All that we can do is advocate for our patients, get our patients to help us in the process. And the AP, you got to keep pushing the AP.
But I'm going to tell you something more about Dr. Mawire. Dr. Mawire, not only did he walk away back with backdated stock options, which is terrible, and that amount of money for malfeasance, he had a $5 million a year pension on top of everything else he got. But we can't spend $10 to prevent a child from dying by suicide. How is that?
I've got to tell you, I can remember it was 1990. I was on, I won't say the insurance company's name. I was asked to be on the physician advisory board. I was one of two pediatricians. And I remember we wanted to get a 50-cent increase in doing a bilirubin in the office. 50 cents. It came down to a vote of the committee who had internists, surgeons, OBGYNs, ophthalmologists, and they horse traded. We didn't get our raise, but one of the specialties who said, listen, you vote for me. I wanted a $120 increase for this procedure, and I'll vote you the next time. That was part of the problem also. It was of our own colleagues who weren't there. Now that our colleagues who take Medicare have had money taken back, I know it happened to my son, where they got less and less, and some of it went towards us in primary care to help pay for giving us a little bit more money than we got before. But why would Medicare decrease what they're paying physicians in general per RVU when prices are going up? The cost of labor, your vaccines, the table paper, it just makes no sense at all. And quite honestly, we're going to see a lot of major changes come this January, which probably won't be good for us.
But Medicare did do a good thing for primary care. They invented that G2211 code that had a value that was supposed to be for care coordination, for doing these extra things. And the insurance companies were supposed to follow suit. And that was a great thing. So they didn't give you an increase, but they put it over here. So that was okay.
But they stopped paying for it.
But what happened?
They don't pay for it.
Nobody paid for it. United Healthcare paid for it.
Now they stopped it.
Now they stopped. So how are you going to get anybody else? This is a big discussion on PBAC. They wrote another letter, but nobody listens. How is Blue Cross going to pay for it if United Healthcare stopped paying for it? If they stayed in the game and forced it to stay in the game, then maybe Blue Cross would have come to terms in Cigna and Aetna. But a very good thing is the managed care Medicaid lines of businesses, some of them in New York that follow a Medicare contract, they do pay for it. But the ones that follow the Medicaid contract, they don't pay for it.
Yeah, it's crazy and it's terrible.
So again, I don't have any faith that the AAP can do anything because this is not going to be won by, first of all, they don't spend enough money lobbying. They spend $1.5 million a year lobbying, which is nothing in DC. And because of their not-for-profit structure, they have to be very careful how much money they put into lobbying and what they say about who they support. Third of all, they will always support the Democratic Party. And this battle calls for getting 60% of the country on your side. I don't care if you just do Republicans, Democrats, whatever wackadoodle party you want. You need 60% consensus to move on things like this. So you have to have friends on both sides of the aisle. You cannot just be on one side if you're going to be effective. But these kinds of battles where you're trying to get Congress, legislatures at the state and federal level to change things are one when the people that vote them and keep them into office complain. They listen to those people. And the reason the hospital system has so much sway, that's why the doctor's reimbursement goes down in Medicare, because it's got to be neutral, budget neutral, is because whenever anybody from the state sits down, in my neighborhood is Inova. Inova owns 85% of the hospital beds in Northern Virginia. Whenever people in Richmond or the Republican governor, Glenn Youngkin, says to Inova, we need to decrease the spend on Medicaid at the hospital level because we have a balanced budget and we can't afford it. It's getting to the point where it's competing with money that goes to teaching kids in K through 12. The Inova CEO says, Governor, I would love to help you, but you are aware that we are the biggest employer in Loudoun County, Fairfax County, Prince William County. And that's where the population centers of the state are. If I take that cut that you're proposing, I'm going to have to fire X percent of females with middle-class jobs in those counties. How do you think they're going to vote when they know they got fired because of your proposal?
I see what you're saying, Herb, but what can be sure? I go to what I really wanted to say is what we need to remember is that, I see that, and I see what they're saying, that females, forget about it. Why do the insurance companies have to be so top-heavy with the number of vice presidents they have? Get rid of 10 vice presidents, and you've got more than enough money to make up for the difference. But to me, the really important thing, and it's what George had mentioned, I've been an advocate for us forever. A lot of people don't like me. I'm very go after things. I'm not afraid to go after things, but that's what we need to do. George is serving now on path, and he might not be happy all the time, but he's putting his 2 cents in, and we need people to be out there and just don't take note. I did. I got 2 special AP awards because I didn't say no. And I was known by the people up top as a hothead, and I wasn't afraid to go after what I thought I had to do because it was on behalf of us, the pediatricians. Yeah, we all want to do well for the kids, and which we do. But if we're not taking care, who's going to be there to protect the children 10 years from now when there aren't enough pediatricians around? So it's constantly getting out there like I do, like George does, like other people. And you seem like a very bright guy, Herb. I don't know why the AP in Virginia doesn't have you getting out there on behalf of the AP of Virginia.
Yeah, Herb.
Because I'm more of a hothead than you are. And I can't stand the nonsense. And to me, it's, if you're going to talk to people, you need to come with the data. We're in Virginia, less than 50% of the kids have a medical home. And we're spending less than 5.5% of every healthcare dollar in primary care. And we're seeing it in the exam room every day. Obesity, overweight kids, depressed kids, anxious.
But you know all this, and this is why you should go to your local newspapers to make it known. The fact of the matter is, you're a bright guy. You do have all the information. You've got the facts. Hothead, all the years when I was in charge of the New Jersey Pediatric Council, I kept my temper in. One time I pounded on the table and I screamed and I yelled at the managed care people who were astounded because I couldn't take it anymore. I went, excuse me?
Sometimes you need to do that. The lawyers will tell you, when the law is on your side, you argue the law. When the facts are on your side, you argue the law. And when you don't have anything on your side, you get up and you pound on the table and scream.
Well,
that's how they win in the courtroom. And so we have to go in with the facts, because what you said about the horse trading, if I go to talk to, I'm just talking about my state because I know the people in my state. If I go to talk to Governor Glenn Youngkin and I go, we need to pay primary care more, he's going to say, Herb, I can't afford it. We have a balanced budget amendment. I don't have the money to put into Medicaid. People don't want their taxes raised. They don't want their sales taxes raised. Then you have to say, but this is 5% of the spend. If you increase it by 50%, you're only increasing the whole spend by 2.5%. So yes, you can afford it. You just can't afford to give a 5% raise to all the Medicaid providers. You need to funnel it into the primary care providers because it's such a small amount. It's not going to destroy your budget. But we don't, that's what you have to inform them. You have to educate them. And
Yes.
it's a tough game. It's a tough game. And the truth is already nationally, 15% of children don't have access to primary care in Northern Virginia. And I said this over and over again and hope that people listen. In Northern Virginia, the DC metro area, if you are my age, I'm 58, and you want a good internist, you better come in with your American Express card and give him $3,000 on top of your insurance, because there is almost no primary care for adults left that is not concierge.
But that's what you want to do when you're talking to the governor.
They said, we're done. We're done. Nobody wants to pay us what we're worth. Then you pay me out of pocket $3,000 and I'll bill your insurance. And then I can make it work and I can do a good job for you.
I understand that's concierge medicine, and the numbers in pediatrics has gone up since this first started. But what you just said is really important. That's what you tell the governor. Listen, if you don't do it, you're going to have fewer people taking care of the Medicaid kids, which is going to be more illness. Your hospital costs are going to go up dramatically. So you're being, what's the expression?
Penny
wise and pound foolish. But but you know, that's what you and other people should do in your state. Your chapter should do that, stating that listen, we have enough pediatricians who are not going to participate in Medicaid anymore. What are you going to do then when you have a 20% increase in hospital costs that you have to bear the brunt of?
This reminds me of, this is going to be a funny story, then we'll end it. Because she's a Democrat, charming lawyer, and very politically active in Virginia. She's in the legislature. And we had dinner. And halfway through the dinner, she just turned around and me. She said, Dr. Bravo, you're adorable. Would you just please shut up? You're a walking encyclopedia. I can't take any more facts. I can't take any more facts. Let's talk on something else. But it's just funny. They try, these people try to be good. I couldn't be elected to dog catcher in my neighborhood. They try to do good, but they have a lot on their plate, and it takes multiple touch points and a lot of persistence and a lot of having the salesperson personality of not taking no for an answer, going back and back without alienating them. It's a very difficult job.
Yeah, it is. We're reaching the end of the show. Chip Hart had the longest episode. I think you just tied him. Rich,
don't tell Chip.
Let's leave you with one last question. Like, after talking to you two, and if I was a young physician asking for advice if I should go into pediatrics, independent practice, I'd be a little depressed right now. What are your thoughts? Were you happy? Is it a good idea?
Absolutely, yes. I just had a young lady in college, pre-med, from a Medicaid family. She wants to be a pediatrician. I said, that's great. You need to follow your heart. You have to be happy in what you're doing. Are there issues that come up? Yes. Yeah. The cost of education, going through medical school is tremendous, the debt these kids come out with. But the fact of the matter is, if you love what you do it, you can't just go to the office and see kids. You have to be able to help, again, as pediatricians, to work with other pediatricians to have changes made in your community, in your state. So life isn't terrible. Listen, we all know, we keep saying pediatrics might be a dying breed. You're using lots of ancillary people to take over from us. And I know lots of great PNPs, very knowledgeable and very smart. But then what comes underneath them? What's going to come underneath the next one will care for our kids suffer. So I've been very happy. I'm a grandfather. I'm around to help my grandkids. Fortunately, my son is a physician. which makes a difference. I'm hoping one of my grandkids will become a physician one day, because when you're in the field, you can get around things. Herb mentioned before about can't get into endocrinology or developmentalist. You're right. In my practice, I pick up the phone, I call the developmentalist directly. You've really got to get this kid in. And all of a sudden, the 6-month wait is, okay, I'll get him in 3 to 4 weeks. They have the openings. We've got to take that extra step to help our patients who really need it and not be complacent like many of our colleagues are. Oh, I'm sorry, I made the referral. You can't get in, you got to wait. No, pick up the phone and make the phone call.
Yeah, there's a lot of, it's not my job. It's
But
somebody
it is
else's
our
job.
job.
I
It
know
is
it's
our
our job. I
And
know
it
it's
is
our
our
job.
problem.
I
know.
don't even think it's a job. So to me, a big part of the joy, and I would imagine it's not being just a physician, is the relationships that you build over time with other colleagues. And Epic and the EHR and texting has, in some ways, really destroyed that.
Yes.
And yes, you're absolutely right. It is not only the right thing to do, but it brings me a lot of joy when I can call the pediatric endocrinologist or text them and say, I have this kid, it looks like this. Can you know, like, oh, let me call you. And I go, I did this, I did that. And they're like, oh, I'm so happy because you're learning from what I taught you. Yes, I said, but now I'm at the end. I don't know what to do next. So I need you to see them. Yeah, give me their name and their phone number and a date of birth. I'll have my scheduling stuff get them in. To me, that collegial, I'm learning from you because you're a subspecialist. I'll do as much of the workup as I can for you, but I'm at the end of my line. Now I need you to take over. And that conversation is the fuel that keeps me going, but it happens less and less.
So I'm going to look at that problem from the financial viewpoint. Probably about 25 years ago, at one of my hospital systems, the president of the hospital came to our pediatric grand rounds and said, I'm getting rid of you. We're not going to have a department of pediatrics anymore or hire people full-time to work here. We don't need you. So what did we do? We went to the ophthalmologist, ENT, the surgeons, everyone else said, hey, listen, if we're not here, you don't get our referrals if we have to go elsewhere. They, because they had the clout with the hospital, got the president to change their mind.
Wow.
Insurance companies know the value of pediatricians because when families want to look at insurance, who do they look for? Oh, tell me about the pediatricians. I'll worry about my internist later or my OBGYN, but I've got 2 kids now. I need my pediatrician. And we forget how much power we have, but we don't use it.
Absolutely right.
Yeah. A
Absolutely.
little bit more than just runny noses
Yes.
and shot givers.
Yes.
Right. And with that, I say thank you for your time and support. Herb, anything?
Thank you very much. I've always enjoyed having a conversation with you, and this has been
Yeah.
wonderful.
Thank you. It's been my pleasure to be here. And hopefully people who listen in will help to try to make a difference for all of us.
Yes.